As you can tell, today we're using a new Zoom format. And so in a moment, I'll walk through the instructions for you to ask questions. Before I do that, however, let me introduce today's speakers. We have Patrick Allen, Director of the Oregon Health Authority. We're also joined by Christine Bartlett, Director of Intensive Care Unit at Oregon Health Sciences University, and Dr. Melissa Sutton, who is a Senior Health Advisor at the Oregon Health Authority. I want to remind folks, as we do each week, that this briefing is intended to offer members of the media the chance to ask questions of our health experts. If you're a member of the public, you are welcome to listen in. However, we are going to limit questions to reporters. And Gabby, if you can advance the slide, and let's walk through how you do that in this Zoom format. Okay, so
to record.
Yes, reporters have permissions to record. So what we're going to do today is ask you to submit questions via the chat feature in Zoom. So please direct your questions to me, Rob Cowie. To do that, if you've joined us by phone, please switch to the web app by using the link provided in the news release. At this time, we're not going to be able to take questions through the phone line. And as I said before, again, this session is for reporters to ask questions. So in the chat, please identify your name, your outlet, and we'll be happy to answer your questions. And then if you need to rename yourself, here are the instructions for doing so. Click on the participants button at the bottom of your screen, look for the box, click on more, and then on rename, type in your name and your media outlet in the pop-up box. And then to ask a question, click on the chat button at the bottom of your screen. The chat box will open on the right-hand side of the screen. Select my name, Rob Cowie, and then submit your question. All right. And once again, here are our speakers. Patrick Allen, Director of the Oregon Health Authority, Christine Bartlett, Director of Critical Care at OHSU, and Dr. Melissa Sutton, Senior Health Advisor at OHA. And so now I'll turn it over to Director Allen.
Great, thanks, Rob. Again, I'm Patrick Allen, Director of the Oregon Health Authority. And as Rob said, I'm here today with Dr. Melissa Sutton, one of our Senior Health Advisors, and Christine Bartlett, Director of Critical Care at Oregon Health and Sciences University. Nurse Bartlett will talk about the situation medical staff at hospitals like OHSU are facing, and Dr. Sutton will talk about the actual number of COVID-19 tests Oregon conducts each week, why we're changing the way we report those numbers, and what it means for Oregon's pandemic response. As we speak today, we're at a dire point in the pandemic in Oregon. COVID-19 is spreading dangerously quickly. Over the past week, we've established new daily records for daily cases and deaths. We're entering a new and critical stage in the battle against the virus. Today, we're reporting 1,306 cases of COVID-19, setting yet another high for the pandemic. Virus-stricken patients are filling our hospital beds in ever greater numbers. Oregon hospitals are facing a clear and present threat. If we don't get COVID-19 under control, the virus will swamp our hospitals with severely ill patients, putting more lives at risk. But I want to underscore one vital point. The virus doesn't set the timeline for anything. We do. We can make choices to feed the virus what it needs, new people to infect, by flouting science, gathering in large groups, and refusing to take the simple precaution of wearing a mask to protect the people around you. Or we can wear masks, limit our social gatherings to one other household at a time, and keep our get-togethers small. That's how we stop COVID-19 from spreading. Maybe you're someone who's worried about a loved one getting sick. Maybe you're someone who's mad about closures and restrictions. Maybe you've lost a job. You're tired and frustrated about your children's distance learning. We all want this pandemic to be over. But here's a simple message. We all have the power to end this nightmare. Wear a mask, keep our get-togethers small, and limit our social interactions to one other household at a time. Now, let me give you an overview on where things stand in Oregon. In total, Oregon's recorded 62,175 cases and now 812 tragic and preventable deaths, including 4 today. The virus is spreading faster. 3 weeks ago, we recorded 3,500 weekly cases for the first time. The following week, we exceeded 5,000, and this past week, we've eclipsed 6,000 cases. People are dying at a faster rate. This week, we surpassed another sad milestone in the pandemic, our 800th death, only 16 days after we crossed the threshold of 700 deaths. Now, this is the point of the news conference where I'm supposed to say our thoughts go out to all the families mourning the loss of a loved one to this virus, and I do extend my sympathies to them. I get emails from people who've lost loved ones. A longtime friend and classmate let me know her mother passed yesterday. Their pain is real and heartbreaking. I'm deeply saddened by every death we report. Based on what we know today, though, COVID deaths are preventable. We can prevent more deaths from happening by taking simple precautions in our lives. Please, before you gather for Thanksgiving, think about the implications of your choices, not just for you, but for your friends, family, and community. Weekly hospitalizations also hit a record high at 212. Our hospital numbers should be sounding alarms to all of us. We currently have 412 hospitalized patients with positive COVID-19 tests in Oregon. We've experienced a 142% increase in hospitalization since November 1st in patients who've tested positive for COVID-19 and a 234% increase over the past month. In a moment, I'd like to give Nurse Bartlett a chance to share her frontline experiences trying to save lives in the middle of this surge. But before I do want to take a moment to talk about testing. Our level of test positivity remains stubbornly high, even as more Oregonians are being tested. There's been a lot of discussion about COVID-19 testing in Oregon this week. Let me preview a few of the points Dr. Sutton will cover. Oregon tests for COVID-19 at a rate that's comparable to most other states in the United States. When the pandemic started, we measured the number of new people tested so we could be as transparent as possible. Now, there are more ways for people to get tested, so we're moving to a test-based reporting system. When we look at the total number of tests performed in Oregon each week, we're right in line with other states on a per capita basis. Oregon's test positivity rate is too high right now and tells us COVID-19 is spreading too fast, even when we shift from a person-based testing calculation to a total test-based calculation. When we recalculate our historic positivity rates using the new method, Oregon's test positivity rate drops significantly. It goes from a shockingly high rate of almost 13% to a merely alarmingly high rate of nearly 7%. While the percentage is lower now, it's still above the level that would indicate declining spread and a safe level to fully reopen schools and businesses. Testing is a vital part of Oregon's strategy to suppress COVID-19. Oregon's increased testing by 60% since the beginning of October. We're sending tens of thousands of Binax Now tests per week to hard-hit local providers and organizing mass testing events across Oregon. We're reserving tests for schools, long-term care facilities, and for surge hotspots, but testing isn't enough. The most effective strategies to save lives are wear a mask, limit your get-togethers to one other household, and keep your gatherings small, ideally 6 people or fewer. Now I'd like to turn things over to Nurse Bartlett.
Hi, and thank you. I'm Chris Bartlett, and it's a privilege to be with you today. I want to tell you a little bit about our story, the nurses at OHSU. As a director of critical care nursing, I work with more than 300 ICU nurses who provide highly specialized care in 4 ICUs at OHSU. This year has been extraordinarily difficult for us as our nurses and clinicians have demonstrated extreme resilience. But with another week of record-breaking COVID positive tests in Oregon, we are growing weary and we're on the brink. But as Patrick said, we are at a tipping point. We know that wearing masks, staying physically distant 6 feet apart, and limiting your gatherings to one other household will help us prevent this disease from spreading further. So much has changed for us in our daily lives. Over the last 9 months, our nurses are risking serious illness and death daily by caring for the sickest patients with the COVID-19. It's dangerous but essential work, and our nurses and clinicians are required to wear much more protective gear than we're asking you to wear. We're wearing tight-fitting masks, gloves, gowns, and face shields 12 hours a day to help stop the spread of this virus between each other, to our patients, and from our patients. So when we ask you to put on your cloth mask for an hour or two when you're out and about in the grocery store or when you're meeting with other people, please think of us wearing all of that gear for 12 hours a day to keep our patients and each other safe. In ICU, we see every day how the reality of how dangerous COVID-19 is. Over the last 9 months, our nurses and our clinicians have cared for patients fighting to survive this debilitating disease. Often, our patients are in isolation, unable to touch or talk to their loved ones for weeks at a time. We know as healthcare providers that the support of friends and family is important. It's a really important part of the healing process, and it breaks our heart to have to limit visitors. And watching our patients struggle without their loved ones by their side is agonizing to us. But what weighs heaviest on us is that this is preventable. Please stay home with your family now so that your loved ones and your family don't have to be in our ICUs over the holidays. Critical care nurses choose to do this challenging work because caring for critically ill patients is our calling. We find it a privilege and a responsibility, and we have trained long and hard, and we wholeheartedly embrace our passion to serve. We are committed to providing the best and safest care, but the current onslaught of COVID-19 cases is taking a heavy toll. We are overwhelmed, we are bone tired, and I'm here today to plead for your help. Like OHSU, all the Portland City hospitals in the metro area and around the state are severely strained. Physical beds may be available, but there aren't enough caregivers to staff them at times because they've taken paid leave, they're out sick, or have been exposed to the virus in the community and are quarantined. In the spring, when the community cases of COVID-19 were low, we had very few staff quarantined. Today at OHSU, we have over 50 critical function staff on quarantine, and the vast majority is due to community exposure. When social gatherings occur and people spread the virus, it takes nurses and clinicians away from providing all essential care, not just care to COVID-19 patients. OHSU and other hospitals and health systems are already postponing surgeries necessary for non-COVID healthcare conditions to make room for the COVID sick patients. Fewer people available to work means hospitals choose between asking those who can come to work longer hours and overtime, or limit fewer and offer fewer services. When we have fewer nurses, we are not able to care for as many patients. Because this is a nationwide problem, we're unable to recruit ICU trained travel nurses like we have in the past from other states to help. Every health system in our country is grappling with this issue, and we can prevent it. It's important to remember that our clinics are not immune to this either. They too are struggling to keep up with the patient volumes due to insufficient staffing, because not all people with COVID-19 are hospitalized, but they still need physician care in the clinics. The good news, and what I'm here to share, is that you have the power to ensure that we have enough hospital beds and healthcare providers to take care of all who need our care. In-person social gatherings outside of our household, or our bubbles, as we call them, is dangerous, and that's including Thanksgiving week. We are asking that you stay home, you keep your gatherings small to one household, you wear your masks when you are outside or with other people, and you physically distance when possible. By staying home and canceling your social gatherings and following the safety measures that have proven so effective in the past, we have flattened this curve twice and we can do it again. You can stem the tide of the COVID-19 spread in Oregon and give our critical care nurses and clinicians hope that the weeks after Thanksgiving won't be the worst weeks yet. On behalf of all of our nurses and clinicians, I want to thank you for your sacrifices this year. We know it's been hard. Your willingness to follow Governor Brown's protective measures has and will have a significant effect on our ability to safely care for all Oregonians. Thank you so much. Happy Thanksgiving. And Patrick, I hand it back to you.
Thanks, Christine. Now I'd like to turn things over to Dr. Melissa Sutton from the Oregon Health Authority.
Thank you, Director Allen, and thank you, Nurse Bartlett, for your work on the front line. I'm Dr. Melissa Sutton, one of the senior health advisors here at OHA and a lead medical expert for our testing strategy. There have been questions recently about our testing capacity and our strategy for dealing with the surge of COVID-19 cases. Let me provide some data to underscore the points that Director Allen made earlier. Currently, Oregon reports the number of people tested for COVID-19 each week. Our data shows that to date, more than 966,000 people, nearly 1 in 4 Oregonians, have been tested for COVID-19. This morning, I want to announce a change in the way Oregon reports the number of tests performed in our state and tell you what it means for our pandemic response. Up until this point, we have counted and reported people tested because our infectious disease database was created and formatted to track people as opposed to laboratory results. Many other states report people tested for this same reason. At the same time, other states and the CDC report the total number of tests performed, even if the same person has multiple tests. According to the CDC, both methods are acceptable. Early in the pandemic, testing was occurring mostly through the Oregon State Public Health Laboratory or in hospital systems. Cases were being retested frequently. As the pandemic has progressed, many more people are being tested for COVID-19 and much more often. Testing criteria and practices have expanded dramatically, and today we recommend testing anyone with symptoms, however mild, as well as all close contacts of cases. So who's being counted and who's not being counted in our current testing reports? Under our current method of counting, we report anyone who tests positive for COVID-19. They are then excluded from being counted again for 90 days because reinfection is very unlikely to occur during that period. We report any person who tests negative for COVID-19, but only the first time they test negative. People who test negative are not counted again, no matter how many additional negative tests they take, until they test positive. As a result, our people tested metric really represents the number of new people tested each week and is significantly undercounting the true number of COVID-19 tests performed in Oregon. For this reason, we will now be reporting the number of tests performed as opposed to people tested. So based on the number of tests performed, where does Oregon stand in relation to other states? Oregon is not at the bottom of the list when it comes to COVID-19 testing. We're in the middle of the pack. The CDC publishes a data tracker that allows for state-by-state comparison, and it shows Oregon ranks 30th in the rate of tests performed per 100,000 people. The CDC tracker also shows that more than 1.9 million PCR tests have been performed in Oregon since the beginning of the pandemic, nearly as many as in neighboring Washington state, which has a substantially larger population. And now I'd like to review 2 graphics which demonstrate the differences between our current method of counting people tested and our new method of counting tests performed. In this first graph, we see that in the early pandemic, measuring either people tested or tests performed resulted in similar figures. However, in September, as case counts began to rise, these two methods began to diverge. And as case counts have sharply increased, so has the difference between the two methods of counting. At the far right edge of the graph, we see that while we counted 49,000 people tested the week of November 8th, there were more than 113,000 tests performed, a significant difference. What accounts for this difference? The difference is explained by people who have been tested previously and excluded from the count under our current method. People who have been exposed to the virus more than once, people tested for work, people tested in congregate living facilities, people tested as part of an outbreak investigation, students tested at universities, and others. The pandemic has been with us now for 9 long months, and the risk of exposure is ongoing. How will Oregon's percent positivity rate change under the new test-based reporting method? Let's take a look. In this second graph, we see that the percent positivity calculated by people tested versus tests performed tracked very closely until case counts began to rise in September. And over the last few weeks, as case counts have skyrocketed, the difference in percent positivity as counted by these two methods has sharply intensified. At the far right edge of the graph, we see that our most recent percent positivity calculation of 12.9% drops to 6.7% under our new test-based method. While percent positivity calculated under this new method is dramatically lower, we still consider 6.7% unacceptably high and evidence of widespread community transmission. And now I'd like to speak about how we are increasing testing in response to the current surge in COVID-19 cases statewide. As you know, in October, Oregon began receiving shipments of Abbott Binax Now point-of-care antigen tests from the federal government. We have received 440,000 Binax Now tests and deployed more than 160,000 to partners, including local public health authorities, tribes, hospitals, federally qualified health centers, university and school-based health centers, prisons and jails, shelters, and other partners. Distribution has been brisk. Using those tests, we have significantly expanded our testing capacity. Since Oregon began receiving the Abbott Binax Now tests, the number of tests performed has increased by 60%. Again, to more than 113,000 last week. Let me say that again. Since October, the number of tests performed has increased by 60% to more than 113,000 tests last week. For a lot of reporters on this call, I know you've been wondering, why hasn't that increased capacity been reflected in our daily and weekly testing numbers? I hope that the data I've shared today about our reporting methods explains the difference. We continue to face testing constraints. Binax Now tests must be administered by trained personnel at federally certified locations or locations that have obtained a waiver that allows for testing. And federal allocations of Binax Now tests are slated to end at the end of this year. Therefore, OHA is using this testing capacity to increase test availability in the short term as we continue to build long-term testing capacity. OHA is actively working to recruit new testing partners to meet the requirements necessary to perform these tests. In addition to continuing to deploy the Binax Now tests, OHA is standing up a series of low-barrier community testing events in partnership with HHS through the end of the year. Testing events are currently planned in 12 counties. They are free and open to everyone. These events do not require identification or a physician's order. You can go to the OHA COVID-19 website for more information on these events. Oregon, like many other states, is working hard to bring more testing to Oregonians and to ensure that tests reach our most vulnerable populations. But we know a test doesn't protect you from COVID-19. As Director Allen and Nurse Bartlett both said, wear a mask, stay physically distant from others, avoid gatherings, stay home when possible, and wash your hands. And now we are happy to take your questions.
This is Rob Cowie again. Thank you to our speakers, and thank you to reporters who have sent questions in. We'll begin working our way through those questions, and bear with me as I scroll through the chat. And again, if you have a question that you want to ask one of our speakers, please send me that question directly in your chat box. Let me begin with questions from Lachey Wesley at K2. This is for Dr. Sutton. Will the Oregon Health Authority change testing guidelines to allow more people without symptoms to be tested? It's a three-part question. And then on other topics, can you explain why capacity limits are different for churches and retail stores? And then third, on the vaccine, if U.S. regulators approve vaccine emergency use, how quickly will it be available in Oregon?
All right, I will do my best. So will we be changing testing guidance to allow more asymptomatic testing? So at this point, we know that we have widespread community transmission. And that's why one of the approaches we are taking to the surge is planning this series of pop-up low-barrier community testing events. So these testing events are open to anyone. It doesn't matter if you have symptoms. It doesn't matter if you have exposure. It doesn't matter if you have identification. The testing is free. And I think that will certainly allow much more testing of people without symptoms. In terms of a longer term change to our strategy, we are not planning to recommend widespread asymptomatic testing beyond the surge period. And then regarding the question of capacity limits, I'm wondering if I can turn that over to Director Allen.
Yeah, Rob, could you repeat that question, please?
The question is, why are the capacity limits for churches and retail stores different in state guidance?
Yeah, thanks for that. And I think my understanding is the general difference is the nature of exposure. In a church or similar kind of a setting, you're gathering with a fixed group of people in a defined space for some period of time. In a retail environment, interactions with other people would tend to be fleeting as you pass each other on the aisles or interact with a cashier or something like that. And so the nature of the exposure is different, and that's the general thinking for that. I think I can also take the third question about vaccines. I think the biggest issue is going to be what's the distribution plan from the federal government and its contractor McKesson to make that vaccine available in the state. Depending on which vaccines become available, one of the two that look like they're going to become available first have some significant distribution challenges around the temperatures that they need to be maintained at, and the size of the shipments and how large or small they are, particularly as we try to serve rural areas. And so we'll need to know a little bit more a little bit more about those details before we can be very definitive about that. But obviously, we're going to want to get this vaccine out, assuming it gets emergency approval by FDA, out into communities as quickly as we're able to.
Okay, Pat Doris from KGW asks, Dr. Sutton, do you really believe 64,000 people a week are return testers?
Yeah, thanks, Pat, for that question. I do. When you think about the fact that almost 1 in 4 Oregonians have been tested to date, I think it makes sense that we've seen the pool of people who can be counted shrink pretty significantly as our case counts have skyrocketed. I think it's important to recognize that, we have 60,000 Oregonians living in congregate care, 30,000 Oregonians working in congregate care settings, thousands upon thousands of pre-procedural tests happening every week. There's a lot of repeated testing happening in Oregon, and we haven't been counting that.
Okay, thank you. Sarah Klein from the AP asks, how does Oregon's COVID-19 situation, specifically the positivity rate and surge in cases and hospitalizations, compare to other states? Are we a hotspot?
I think I can tackle that one. As we look at data across the country, the numbers in Oregon are concerning, and the pressure that's being put on our hospitals is real. But short of being on an island, I would sure rather be us than some other parts of the country. We continue to be one of the lowest states in the country for rate of new infections, one of the lowest states in the country for fatalities. Our positivity rate, even using the old methodology, is middle of the pack for states. And so I would say we're in a place where we're concerned, and we want Oregonians to take action, like washing their hands, maintaining their distance, wearing masks, limiting their gathering size, so that we don't become a hotspot.
Yeah, and I'd like to echo what Director Allen said. So our positivity rate has consistently been relatively low compared to other states. It has jumped recently, but so have many other states. And our hospitalization rates, when compared to other states, are actually quite low. We have one of the lowest hospitalization rates in the nation.
Gary Warner from EO Media asks, how many patients are having to be sent out of their hospital region to another hospital region?
I'm not sure we've got someone here who's completely versed in that. Dr. Sutton, you want to take a crack?
Yeah, I think what we can say is that, transfers in Oregon from the rural regions to the Portland region are quite common, and that pattern has continued. I do not believe that we have yet started seeing one region needing to transfer in, but all of our regions are becoming dangerously close to reaching capacity.
And Gary, we can follow up with you and check in with the team that monitors hospital capacity and see if there's more specific data we can share. KEX asks, which method of COVID-19 test reporting gives the most accurate picture of the test results? Dr. Sutton, I think that's for you.
Can you repeat the question, Rob? Which method
of COVID-19 test reporting gives the most accurate picture of the test results?
Yeah, that's a good question. It's not really a question of accuracy. It's that we're counting two different things. So, up until now, we've really been counting the number of new people tested. And that was a really useful way of measuring testing capacity statewide until very recently. Now we will be counting the number of tests performed, because with all of the repeated testing that we have going on in state, and just the sheer volume of people being tested, that will give us a better idea of the amount of testing happening in Oregon.
And I'm not sure if the question is about testing calculation or in terms of specific types of tests, PCR versus antigen. Do you have thoughts about which of those are more accurate?
Sure. Yeah, sorry. Maybe I misunderstood the question. The PCR or molecular tests remain the most accurate tests on the market. The antigen tests perform okay compared to the PCR. We do see that they are more likely to produce false negatives, and we believe they're more likely to produce false positives as well. We're still, looking for evidence coming out daily on how those tests are performing in real life.
If I could add, this though has really been one of the challenges of this pandemic. As we know, significant transmission occurs amongst people who either are asymptomatic or pre-symptomatic. And we know that all the tests, including the PCR tests, have high rates of false negatives in people who don't have symptoms. And those two things are just a huge challenge in terms of how to do effective testing, and are really a piece of why we are extremely reluctant to have widespread asymptomatic testing, because a negative test, usually you think it means that you don't have the disease you tested for. And in coronavirus, a negative test just simply does not mean that.
Dick Hughes asks, some churches have started house churches where 10 people gather at a home to watch the church service online. Are 10 people allowed for that because it is a church situation, albeit in a home? Or is that disallowed because it's more than 6 people and more than 2 households?
I would, I'll go ahead and take a crack at that. And I would say the guidance is 6 people from no more than 2 households. And if you are doing a gathering for whatever purpose that is more than either of those measures, that's outside the guidelines.
Okay, Les Seitz from the Malheur Enterprise asks, the CDC changed its Thanksgiving advice yesterday, advising no travel and stay home with just your household. Will OHA change the governor's guidance on the 2 households limit of 6?
No, at this stage, I think we're going to continue to maintain the guidance that we've issued. The point of all of this is reduce the number of people you have interactions with, and whether it's 6 from 2 households or a single household. I think the point is, the bigger the gathering, the more risk and the more you're potentially contributing to spread in the community.
Brenna Kelly from KPTV asks, I've talked to a number of medical providers, from county health departments to senior living facilities to hospitals in the Portland metro area. I'm told from the counties that, I think she's referring to the Binax Now antigen tests, aren't being distributed, and locations that have them aren't widely using them because these rapid tests are unreliable. When the governor announced at the beginning of October that the state would be receiving upward of 80,000 rapid tests per week, this was described as a huge gain for the state. From my conversation, this is not the case nearly 2 months after this announcement. Can you explain this?
Yeah, the Binax are being distributed. So I'm not sure really what to say about that first point. We do know that some systems have been reluctant to use them, and I think that we've provided very clear guidance spelling out how they should and should not be used. If a healthcare system has more accurate testing available, such as PCR testing, with adequate turnaround times, and I would call that, less than 48 hours, then I understand why they would prefer to continue using the PCR test. But I think there are places in Oregon that don't have PCR tests available or don't have an adequate turnaround time. And I do think those places are using the Binax tests. And as the surge progresses and we see more strain, on getting testing in Oregon, I think we'll see increasing use of the Binax antigen tests.
I just want to amplify a part of what Dr. Sutton just said. The Binax now test is a weaker test than other tests, but a gold standard PCR test that takes 7 days to come back is weaker still. And so while we haven't yet seen the median turnaround times increasing, we know from experience that that's likely to happen. And so as those turnaround times increase, I think a rapid answer from an antigen test is a far better alternative to a long turnaround on a PCR test.
A couple of follow-up questions from reporters. Pat Dorson, KGW, asks if we can quantify the amount of testing capacity each week in the state.
Pat, that's a tough question to answer. So, we think that, so let me say it this way. What we can quantify is the testing capacity that Oregon laboratories have. The issue is that a lot of the testing done in Oregon is done through commercial laboratories, national laboratories like Quest and LabCorp. Those laboratories can't tell us what their capacity is because their capacity changes as more tests are ordered in other states. So, we've really been thinking about it as if the number of tests that we're seeing performed is fairly close to the testing capacity that we have. And that's because we do continue to see supply chain issues. And right now we are also seeing staffing bottlenecks. In fact, that's I think the number one concern that I'm hearing from partners on the ground. We seem to have enough of the kits and enough laboratory space to do the tests, but we're having a difficult time finding enough people to collect the testing specimens.
A couple of additional follow-up questions from Gary Warner at EO Media. Are you concerned that changing the infection percentage in a way that lowers the number could be used by freeze opponents as an argument that the state has been overreactive? And then also, why is federal aid ending at the end of the year?
Well, in terms of federal aid ending at the end of the year, that's when the bill that managed to get passed expired, and Congress has not seen fit to pass further legislation, despite our and every other state and all kinds of other advocates' desperate pleas that they do that, because we desperately need additional resources to be able to continue doing the work that we're doing. In terms of the first question, you have to do what is the right thing in terms of the right way to report data that's the most reflective and useful to be able to describe what's going on. And there are people out there who have pointed to almost every step we've taken as evidence of some kind of a scheme or whatever. I've had just huge numbers of people email me or talk to me about the fact that the pandemic isn't serious unless our hospitals are full and people are dying. And we are there now. We're at the place where our hospitals are stressed and people are dying. So it's hard to anticipate what people are going to use as evidence of some kind of a scheme. We're here to provide the best information we can and give people some sense of how our circumstances are extreme and that we need them to stay socially distant, wear masks, limit their gathering sizes, wash their hands.
Brad Schmidt from the Oregonian asks, under the new testing reporting methodology, Oregon didn't pass the July peak until early October. Of the roughly 30,000 additional tests reported, how many of those are tied to repeat testing among priority groups such as nursing home workers, hospital workers, etc.? In other words, is the reported increase likely concentrated among a select group of Oregonians who are receiving repeated tests? And does OHA have an estimate for how many people are being tested repeatedly?
Brad, that's a complex question. and I know you are well versed in testing. Let me start with the end of the question. So in terms of an estimate of people who are being tested repeatedly, I mean, I think the estimate is the gap we see between the two methods. You know, the issue is that when we begin to use this new method and we talk about the number of tests performed, that becomes an aggregate number. So we're not looking at individual people anymore. And so we do lose some of the finer data that I think you're after. So for example, I wouldn't be able to tell you once we transition to the new methodology, if Jane Doe was tested last week and then tested again this week and again the next week, because we would no longer be tracking that individual, we would be tracking tests. Is there a follow-up question to that? Did I capture everything?
Looks like there may be some more questions coming. Here's another follow-up from Gary Warner at EO Media. Lane County is seeing a big spike in cases. The New York Times reports that more than half of COVID cases at Oregon colleges are at the University of Oregon. With students statewide going home for Thanksgiving, returning, then going home for Christmas and the winter holidays, then returning, that sounds like a terrible situation. What is being done to stem the flood?
What I know is a great many colleges and universities in Oregon and around the country are actually ending their, if they're on a semester system, their fall semesters now, and not bringing students back until much later than they ordinarily do. I don't know the circumstance for quarter schools or what the exact schedule is at the University of Oregon, but the governor's guidance, along with other West Coast states, to self-quarantine after travel is exactly on point. If people are coming from hotspot areas and they're traveling interstate or those kinds of things, having them quarantine when they arrive is really helpful.
Additional follow-up from Brad Schmidt at the Oregonian. Does the Oregon Health Authority believe the new methodology is an accurate representation of the state's ability to test more people? If the numbers essentially are capturing repeat tests among a select group of people who don't have symptoms, are being tested for precautionary reasons to prevent outbreaks?
Well, I'll take a crack, and Dr. Sutton might want to pile on. Again, I don't think it's a question of accuracy. I think both methods are accurate in terms of what they're reporting. I think the question is what do we need to report, and how useful is that report? And I think when we're trying to figure out what's a question like what's the rate of positivity, counting up all the tests and figuring out how many positives there are amongst all those tests, regardless of why the test was taken, is really, really useful. And I think as we try to contain the spread, driving down that positivity rate helps, I think, answer the other half of your question, if I follow it, Brad, which is, are we testing enough discrete people to be able to hunt down the infections and be able to contain them through the usual tools that we use? Dr. Sutton, do you want to add to that at all?
I think I agree with everything you said, and I think that the new methodology reflects better the amount of testing happening in Oregon. It's really not about accuracy, it's about what figure you're presenting. Right now, we want to know how much testing is happening out there, and we know that there's now become this great gap between the number of people being tested and the number of tests being performed. We need to know the number of tests being performed with the amount of cases that we have now. And I think that's what those graphs were meant to demonstrate, that the two methods were actually quite similar until we saw the big spike in cases this fall.
I think the other thing that is worth pointing out is that the two concepts that you're articulating, Brad, really kind of converge because although there's a big chunk of repeat testing that's stuff like the 40,000 elective procedures a month that get done that in many cases capture people more than one time, those kinds of things. The other repeat testing in long-term care and in certain workplaces really is focusing testing on it's repeat testing because those are the high-risk environments. And so I think that's appropriately captured because it's capturing testing, trying to stay ahead of places where infections are more likely to spread.
Okay, Lisa Balick from COIN has a question. Lisa, appreciate your patience and apologize for the technical difficulties. But here's Lisa's question. The Oregon Restaurant Association is suing the governor over the 2-week freeze, saying it is arbitrary and the numbers don't show a link. Why are they being included? Some argue that businesses are being penalized because there's nothing legally that can be done about private gatherings.
I'll take a stab at that one. So, we worry about restaurants because people congregate in restaurants. And right now, people congregating is very dangerous. In restaurants, people also remove their masks to eat and drink. And we worry whenever people come together in shared indoor air and do remove their masks. We know that there's an increased risk of transmission. I don't know, Director Allen, if you'd like to add to that.
Yeah, just to the second part, I think the governor's been taking some heat because she has, in fact, provided guidance and an executive order that creates enforcement mechanisms for private gatherings. Now, I think she has been clear that the intent is education and communication, but that particularly for large gatherings, she has intentionally created an enforcement mechanism and asked for law enforcement coordination along those lines. So I don't think it's true that we can't enforce restrictions on private gatherings. And to the restaurant issue, I kind of shake my head. 4 or 5 months ago, we got the exact opposite question. Why haven't we shut down restaurants? And now that we're doing a freeze again that impacts restaurants, we're getting the question, why did we? So it's kind of challenging to deal with that issue on either side. But as Dr. Sutton says, the point is gathering together, and especially gathering together without masks. And whether that's something you do in your living room with several families or something that you do with people outside your household in a restaurant or any other setting, right now, that's really dangerous.
So some related follow-up questions. Lisa Balick from COIN asks, in the past, the health authority has said that the numbers don't show a link to transmission of COVID-19 in restaurants and bars through contact tracing. And then Brenna Kelly asks, why not allow outdoor dining?
Well, as I'll take the second half of that and maybe give the first half to Dr. Sutton. We're working together with the governor's office now on basically outlining what the guidance is going to be in a post-freeze environment. And I think we're looking at all these kinds of issues around what are the higher and lower risk kinds of activities and trying to closely calibrate that. But we really need this freeze period to hopefully break the back of the chain of transmission that's going on right now and is driven by people gathering without masks.
Yeah, I'll just add that, contact tracers ask very detailed questions of cases, and the information that they gather is extremely useful, but it is very difficult to gather the right kind of information about visiting restaurants and bars, something that's so common, and actually see that pulled out as a risk factor. It's something that's really best studied in other ways. I will say that, there have been many, many case reports and then some contact tracing data from other states that have shown risk associated with dining in restaurants and bars. So, again, I think it's about where you congregate, and then congregating without masks and congregating in shared indoor air. We just know that that's dangerous.
Okay, looks like we have an additional follow-up question about testing, again from Pat Doris at KGW. If it's difficult for the health authority to quantify the weekly capacity, how are we able to say whether we need more tests from the federal government?
Yeah, thanks, Pat. So it is difficult for us to say exactly what our capacity is to test in state. What we do to estimate the number of tests we need in state is we actually rely on modeling. We look at how many cases we think we're going to have at a certain point in time. We typically pull that data for the first of every month. And then we assume that each one of those cases has 10 close contacts that should also be tested. That gives us an estimate. It's not accurate, but it's something that we can track over time and work towards in terms of testing capacity.
Okay, we have time for one more question. Gary Warner from EO Media asks, what's the timeline for widespread vaccine in Oregon?
Completely unknown.
Okay.
Seriously, we have an application allegedly being made to the federal government for emergency use approval today. We don't know when that will be approved. We don't know what the initial quantities that will be shipped are. We don't know what other vaccines are going to become available. We don't know what those quantities will look like. We don't know what production capacity is. We don't know what distribution channels are. And so I think the answer is it's completely unknown when it'll be widely available.
Let me give some hopes, though. So I think we hope that we'll see initial doses going out this winter or spring, and that we will see ongoing vaccination expanding throughout 2021. Again, it's a hope, because as Director Allen said, we're still waiting for a vaccine to receive approval, and we have numerous challenges ahead of us in terms of distribution and manufacturing.
Okay, so that brings us to the end of our time. Again, I want to thank our speakers for joining us today, and thank all of you who logged in and asked questions, and we'll be happy to follow up with reporters who didn't get your questions answered outside this briefing. Next week, due to the holiday, we don't have a media briefing scheduled. However, we will be back again the following week. Thank you all for joining us.